I'm Sunil Rao, interventional cardiologist at NYU Langone Health System, and I'm pleased to talk to you today about the upcoming ACS guidelines released by the American College of Cardiology and the American Heart Association. Joining me are my two co-chairs of the guideline statement, Dr. Michelle O'Donoghue and Dr. Mark Rule. Michelle, do you want to introduce yourself?
Hi, I'm Michelle O'Donoghue. I'm a cardiologist at Brigham and Women's Hospital in Boston and a clinical trialist.
Hi, Mark Ruel. I'm a cardiac surgeon in Canada, in Ottawa, at the University of Ottawa Heart Institute, and I'm very pleased to be speaking with you today.
We want to thank the American College of Cardiology and the American Heart Association for developing these acute coronary syndrome guidelines. And we also want to thank our partner societies, the American College of Emergency Physicians, the National Association of EMS Physicians, and the Society for Cardiovascular Angiography and Interventions. We also owe a debt of gratitude to our writing committee, who worked really hard to bring this guideline in on time and really have a comprehensive overview of the best practices and the latest evidence related to acute coronary syndrome management. Mark, it's interesting. I mean, you're a cardiac surgeon. Do you want to talk to us a little bit about why cardiac surgery was involved in this document?
Well, thanks very much, Sunil. I think it's a great question. And like you, I want to thank the societies who have sponsored the guideline. I think it's quite forward thinking of them. A lot of these patients, as we know, you have ACS end up having surgery. And if you look at the surgical trials, or in general, maybe that compare PCI versus CABG, or even within surgery themselves, those trials often have a fair proportion of patients who came from ACS presentation. So typically, I venture the number about 40%. So it's very relevant. I think all of us see at our institutions that many of the patients who undergo surgical revascularization, or even worse, surgery for complications of myocardial infarction, obviously presented with an ACS. So I think it's very relevant to surgeons as well. And I really, again, to your point, thank the societies for having the forward-thinking foresight of including surgery as part of the guideline development.
That's terrific, Mark. And I think as we start thinking about more team-based care, the integration of all of the specialties that interact with the patient with acute coronary syndrome is really fundamental to delivering high-quality care and really sort of baked into this guideline document. So the question may be, why update the guidelines now, right? I mean, we've had ACS guidelines that have been separated by non-STEMI as well as STEMI. Well, the reality is that the evidence tends to evolve very, very rapidly. We have several kind of legacy recommendations in this document that we'll review. And some of those, I think, are really founded in a strong database of evidence. And those didn't need to be updated. But now we've got a lot of new clinical trials that are related to antithrombotic therapy, as well as mechanical circulatory support for shock, the use of intracoronary imaging, for example. So those kinds of things really needed to be included in the best practices for treating patients with acute coronary syndrome. A couple of, I think, key facts are important about this document. The first is, we've become much more sophisticated about detecting lower levels of myocardial injury. And the scope of the document, really after consensus from the writing committee, was really to focus on those myocardial infarctions that are due to plaque rupture. And that really is defined as type 1 myocardial infarction. So this guideline does not extend out to type 2s. It does not include MINOCA. It's really focused on the type 1 MIs, where we have the largest body of randomized trial evidence. And I think what we're going to do here is go through some really important recommendations. Some of these are legacy recommendations, as I mentioned. Some of them are new. And I think it's important for everyone to not only read the guidelines, but understand how all of these recommendations fit together for that patient journey from the time they present to the emergency department all the way through to the time of discharge, and then making sure that we implement best practices for secondary prevention so that we reduce the patient's long-term risk. So Michelle, let's start talking about antiplatelet therapy. I mean, this is foundational for patients with acute coronary syndrome. We have some legacy recommendations, but we also have some new ones. Talk to us a little bit about upfront antiplatelet therapy. And what I was hoping you'd touch on is sort of what we used to call preloading or loading the patient with P2Y12 before the cath lab, as well as the preferential use of P2Y12 inhibitors, because there are a few that are available now commercially for use. So talk to us a little bit about that.
Yeah, thanks, Sunil. Just like you're saying, I mean, it has been an area of great confusion through the years. And so we've aimed to try to split this up into two different concepts. One is the management of patients while they're in the hospital. And then the second topic that is also always very controversial is the duration of dual antiplatelet therapy following hospital discharge. So to start with, during the hospitalization itself, we are endorsing the preferential use of ticagrelor and prasugrel for many patients. Now, when I say many patients, we appreciate that ticagrelor and prasugrel are perhaps not going to be the first choice for a patient who is at higher risk of bleeding. But for many of your lower bleeding risk patients, and for those who otherwise don't have a contraindication to their use, especially after PCI, ticagrelor and prasugrel are preferred. For a patient who's otherwise being medically managed without PCI, that's where there's more evidence where ticagrelor, prasugrel hasn't been studied in the same sense or shown the same clear benefit in that setting. When it comes to preloading, that is another area that remains controversial. We have a Class 2B recommendation allowing for preloading with ticagrelor or clopidogrel for patients who are going to be waiting more than 24 hours before going for coronary angiography. Class 2B means that it may be considered, and so, we appreciate that there will be differences of opinion on that particular topic.
That's great. And I think these are really, really important recommendations for people out there who are taking care of patients with acute coronary syndrome. One of the interesting, I think, areas that you briefly mentioned, I'd like to get into a little bit more, is this whole idea around reducing bleeding risk from long-term dual antiplatelet therapy. And we have patients who are older, patients who are requiring oral anticoagulation, for example. And there have been a lot of randomized trials that have looked at these so-called de-escalation strategies. Our document actually does mention that. So do you want to talk a little bit about what some of the bleeding reduction strategies we have in the document?
Yeah, so many of the landmark trials that studied dual antiplatelet therapy tended to treat patients for at least 9 to 12 months post-ACS. And so that's where a lot of those sort of legacy recommendations originated from. But of course, we now have a growing body of evidence to support that in some instances, shorter durations of dual antiplatelet therapy may be appropriate. So we have now implemented bleeding reduction strategies within the guidelines. I'll break those down in a few different ways. One is that for patients who are on dual antiplatelet therapy, consideration should be given to a proton pump inhibitor, which has been shown to reduce gastrointestinal complications, including GI bleeding, for patients who require DAPT. This is perhaps even more particularly relevant for those patients who also require an oral anticoagulant in the background as well. Another important new recommendation that we have is that there's now a Class 1 recommendation that ticagrelor monotherapy can be considered for patients 1 to 3 months after PCI if they have thus far tolerated a combination of aspirin and ticagrelor. So we have a growing number of clinical trials that have shown that that type of strategy of using ticagrelor alone quite dramatically reduces the risk of bleeding. So that strategy of aspirin discontinuation does have an important impact for reducing bleeding. And thus far, the body of evidence that we have suggests that that does not come at the price of an increased risk of major adverse cardiovascular events. There are other strategies that can be considered as well. Just another important one that I'll underscore is that for a patient who does require an oral anticoagulant, that aspirin discontinuation is recommended after 1 to 4 weeks post-PCI.
If I may add, I think the same considerations that Michelle summarized so nicely, they apply to surgical patients as well. As you know, we went through the conundrum of evaluating the evidence of post-ACS CABG performance in terms of administering DAPT or not. And although the evidence that we have is post-randomizations from the major trials, from anything from clopidogrel to even ticagrelor recently, these are fairly inferential in that there's, even in those patients who had CABG, there's a decrease in MACE. Therefore, the recommendation applies also to patients who had an ACS and then undergo surgical revascularization. Now, is it applied across the globe evenly? Probably not, but certainly that there was not enough differences between the post-ACS surgery population and non-surgery population after ACS to change that strong recommendation that we made for that for a year.
Yeah, thanks for pointing that out, Mark. What I'd also like to get your thoughts on is the whole issue around cardiogenic shock due to acute myocardial infarction. This is a really, really popular topic now. Everyone's talking about it. We're debating, I think, at all of our institutions, the right shock protocol. the composition of the shock team. We have a relatively recent randomized trial that I think informed our guidelines. It's the DanGer shock trial around the microaxial flow pump. Talk a little bit about the recommendation that we made in the ACS guidelines and some of the how we balance the risks and benefits of that particular device.
No, thanks, Neil. And obviously, you know the DanGer shock trial very well. I believe, if I'm not mistaken, that you wrote the editorial when
Thanks for mentioning that.
But we certainly had a lot of debate, and the leadership of the writing committee was really well taken at the time. We were frankly wondering whether this would meet a class 1 indication or a 2A indication, and we certainly debated that a lot. And as we know, DanGer shock was in 360 patients. The mortality signal was an absolute reduction of a little bit more than 12%. But at the price of more safety events and complications in the group that received the Impella microaxial pump. We know, for instance, there were things such as renal replacement therapy, which was performed almost twice as often in the Impella group. So you could say, did that take a role in saving the lives, right? There were other events such as limb ischemia, bleeding, which were more common in the group that were intervened on. But again, with the benefit of mortality and a p-value or a confidence interval closing at around 0.99 in terms of a hazard ratio for death. So we really felt, we debated a lot, and we felt that this probably would be best served by a class 2A indication, given that it's one trial that has a number of caveats. And we hope definitely that the committee is going to endorse this as for what it is. I think the jury is still out, and obviously shock is in need of better data, and this is one of the future directions that we highlight as being very important. We don't have much between DanGer shock and the shock trial from 1999. And in the shock trial, many of the patients, depending how you look at numerators and denominators, about 40% of those patients were surgical. Would it be the same today? Would they get revascularization, especially surgical revascularization, without having temporization of their shock with the device? So there are many, many questions, but certainly it was interesting that we had new data that we could appraise and recommend with a 2-way recommendation in this version of the guideline.
Yeah, thanks, Mark. That was certainly one of the most intense discussions I think the writing committee had, and I think really the recommendation that we came up with as a consensus was based on the balance of the risks and benefits that you appropriately outlined. The document also includes a couple of procedural recommendations in the patients that are deemed appropriate for PCI with ACS. I think to Mark's point, there is a significant proportion of those patients who will require bypass surgery because of the complexity of their coronary disease. But for those patients who undergo PCI, we carried over the class 1 recommendation from the revascularization guidelines for radial approach over femoral approach based on several randomized trials showing a reduction in bleeding, as well as a reduction in mortality in those patients with ST segment elevation MI. The new recommendation, really, or the upgraded recommendation, is for intracoronary imaging guided stent placement, which now gets a class 1 recommendation, really based on the flurry of trials that have come out in the last couple of years showing really a significant benefit of intracoronary imaging guided PCI over angiography guided PCI, some of which have actually also shown a reduction in mortality. So that's a change in the recommendations, and I think something that the interventional community has really been clamoring for a long time. The totality of evidence really does support the use of intracoronary imaging, so I want to highlight that as a new recommendation. Now, there's also the issue of complete revascularization, right? And complete revascularization, we have to be a little bit careful about the definition changes depending on which study that you look at. But when you separate it by STEMI and NSTEMI, we're really talking about patients who have multi-vessel disease, right? They have a so-called culprit, which is relatively easy to identify in the STEMI patient, maybe a little bit more challenging in the NSTEMI patient. And again, Mark, to your point, a lot of these trials that have examined this issue of non-culprit revascularization, part of the inclusion criteria was that they were not candidates for bypass surgery. So that's an important caveat to keep in mind as people start treating these patients with multi-vessel disease. But Michelle, maybe you can take us through very quickly the recommendations around so-called complete or non-infarct artery revascularization in both STEMI and NSTEMI.
Yeah, no, thanks, Neil. Within the STEMI space, we now have several trials that support a strategy of treating non-culprit disease. I think that this is something a very important shift that occurred over the past several years and has now really become a routine part of our practice. So after treatment of the culprit or the infarct-related artery, that there is now a strong body of evidence to support, as you said, for patients who are otherwise not planned for coronary artery bypass graft surgery, that we should consider PCI of those non-culprit lesions as well. The question of timing has been an important one, and there are studies that have looked at whether or not it should be treated at the same time as that primary PCI, if the patient's undergoing primary PCI, or whether or not it should be staged and the second portion conducted a few weeks later. Overall, the recommendation now within the guideline is a slight preference towards doing it all in one go, so to speak. We appreciate that might not always be possible, but the evidence overall supports a strategy of trying to do it all at one time, and there doesn't appear to be any excess risk certainly conferred by doing that. And then I think an important change as well is that we now have extended the complete revasc concept to non-STEMI patients as well. So there are now a couple of trials that have supported the concept that by treating non-culprit lesions for a non-STEMI patient, that you can also further reduce their risk. I think a fairly compelling reduction in hard clinical outcomes for non-STEMI patients as well. Neil, you can comment on this. I know that as an interventionalist, one comment you've made to me in the past is that it's not always clear what the culprit is for a non-STEMI patient. But I think in some ways that maybe simplifies things to some extent when we think about treating significant non-culprit disease in addition to what is presumed to be the culprit lesion.
Yeah, absolutely. And as you know, there are randomized trials going on right now looking at that NSTEMI population and how do you guide the revascularization of these non-culprit stenoses? Is it through physiology? Is it through imaging? Is it through angiography? So again, this is a very, very rapidly evolving space. I want to talk very quickly about secondary prevention. So secondary prevention is really incredibly important in these patients who present with myocardial infarction or acute coronary syndrome. The document spends a fair amount of time on this. Obviously, cardiac rehabilitation, counseling patients about medication adherence, and those kinds of things are fundamental. But we have also some space in the document really dedicated to cholesterol lowering. And we had several international experts on the writing panel. And Michelle, you're one of the leaders in this space. Maybe you can tell us a little bit about lipid lowering therapy and LDL goals.
I think it's such an important one, and it's one that also remains controversial. I think first and foremost is getting patients who have an ACS on a high potency statin. It's something that I think that we all know conceptually, and yet when you actually look at the numbers, we know that a lot of patients are not being prescribed it. And it's a whole separate topic to think about those who are truly statin intolerant, but I think it's important to readdress, certainly when a patient comes in, are you able to push that statin dose up higher? The recommendations from there are that if the LDL cholesterol is 70 milligrams per deciliter or higher, a non-statin lipid-lowering therapy should be added for that patient. And so that includes either ezetimibe, a PCSK9 inhibitor, or bempedoic acid. We know that all of these therapies reduce LDL cholesterol, and by and large, the evidence suggests that it doesn't matter how you lower LDL cholesterol, it's just lowering it that is key. We also now have an important addition, which is a class 2A recommendation for a more aggressive LDL intensification goal. So what I mean by that is if the LDL cholesterol is 55 milligram per deciliter or higher, that you can also add a non-statin lipid-lowering therapy. So perhaps a little bit more in line with the European guidelines, which have used that threshold of 55, and I'm glad that we're taking steps in that direction as well, as it's well supported by the evidence base.
That's terrific. I mean, this has really been a great summary of these guidelines. So, Mark, tell us maybe your final thoughts about the guidelines process and the document and your overall perspective from the cardiac surgery side.
Well, I certainly learned a lot. It was a wonderful, again, I think the foresight of everybody to include two surgeons on the writing committee was extremely appreciated. And I think it's also very relevant to the point that we made together earlier. One of the things we struggle with is ACS can encompass, if we want to, it can encompass everything, right? It can go from the chest pain evaluation to chronic coronary syndrome and optimization of secondary prevention, to Michelle's excellent summary just now. And we really had to draw the line and circumscribe the guideline around ACS, because otherwise it could have been a 2,000-page document, right? And I think you, as chair, Sunil, already kept us focused on ACS, and I hope that the reader will find, obviously, that the document is self-sustaining and wholesome, but also refers to things antegrade of an ACS event and also afterwards, right? Upstream and downstream, if you will. And there's obviously, it refers to other guidelines from the ACC, AHA, which we think will complete this one very well.
Great. Michelle, final thoughts?
Oh, no, it was a pleasure, and I think that working with such a group of thought leaders is just, I think such an important advance in the field. And to also be able to synthesize two separate guidelines for non-ST elevation ACS and STEMI into a single document, hopefully this will make things simpler for readers as well.
Well, I want to thank both of you, not only for this incredible discussion, but also for being part of the guidelines, and working with you was really a privilege, and working with the writing committee was really a privilege and an honor. And I want to thank again the ACC and the AHA for allowing us to be part of this guidelines process and for supporting this video. So, thanks again. And I hope that the readers really find this document extremely useful when they take it to the bedside.
Thank you all.
Thank you.